It is my pleasure to introduce someone whom we all know, Dr. Scott Reetz. Dr. Reetz is one of our graduating chief residents. He is a Wisconsin native. He went to the University of Wisconsin for his biology degree, his master's in public health, and his MD, which made introducing him very easy. Uh, he has been an outstanding resident, as you all know. He's won numerous awards, including Intern of the Year, an award for research, and an award for being best resident selected by the APPs. He has been very accomplished, even more so than many faculty members. I would include myself in that category. Even as a resident, multiple peer-reviewed publications, numerous presentations. As a resident, he is a faculty member for the ACS Inclusive Excellence course, which is an incredibly impressive accomplishment. And hopefully we'll be hearing more about Dr. Reetz's advocacy in the space of rural surgery. He was really a driving force behind the inaugural Creighton Rural Surgery Symposium, which many of you have been able to attend. Due to all this success, sure he had no trouble matching into the University of Washington, where he'll be attending, completing a colorectal fellowship starting a little bit later this year. And with that, I will hand it off to Dr. Reetz.
As Dr. Patel said, I'm Scott Reetz. For everybody who knows me well, I'm sure there's very little surprise that I'll be talking to you about rural surgical advocacy. For those of you who don't know me as well, I've sort of been able to adopt the title, the rural surgery guy, in the residency, and it's kind of a title that I've taken on with great joy and passion. This is, I think, more than just kind of a special interest of mine or a CV builder. This really is an area of real passion and something that I want to continue through the rest of my career. And so we've heard many great grand rounds through the years. I think it's been probably 3 or so years now that Dr. Philippi gave a grand rounds. And he kind of talked about these Jesuit values and how Creighton University has this omnipresent set of Jesuit values here without having some overt religious influence in the work that we do. And so I just wanted to put these up here and really remind you all of these Jesuit values. And I hope that you find them to be kind of present in the work that we've been doing here at Creighton and are represented in some of the things that I'll be talking about here today. So these are my objectives, fairly straightforward. I want to talk to you about why it matters to me, why I think it should matter to you, discuss a handful of the challenges that rural surgeons are facing and rural patients receiving surgical care, and then talking a little bit about how advocacy can play a role in improving surgical care. I, of course, have no financial conflicts of interest to disclose, but I want to start at the outset by saying I am not, nor have I ever been a rural surgeon. I've never trained at a rural hospital, and I'm going into a fellowship for a surgical subspecialty of sorts in colon and rectal surgery. And so I think naturally you should all be asking kind of what authority I have to be talking about rural surgical care. And so to be clear, I'm not trying to convey my own experiences here today as being that of a rural surgeon, but rather just trying to, convey this message that I think as academic surgeons and trainees, we can do a little better job of understanding for the challenges that rural surgeons are facing in delivering care to these rural patients. And at the end of the day, hopefully to help take a little bit better care of our patients coming from a rural location. And so while I'm not a rural surgeon myself, these are my credentials to take care of and to present on this topic here today. This is the metropolis of Fall Creek in northern Wisconsin. This is where I grew up. The K through 12 school district is here in the foreground. There's no stoplights in town. I don't know if you can see my cursor, but our high school basketball coach lived over here. Football coach lived over here. Grandma lived over here. This is very much an everybody knows everybody kind of town and kind of the quintessential small town America. And so to start my talk, I want to take maybe some editorial liberties in talking a little bit about my own experiences and an upbringing in a rural community in northern Wisconsin and kind of have this focus on the impact a rural hospital can have on the community. And, I think it's a unique lens to see the impact of the work that we do here in medicine, and that it's the type of topic that maybe doesn't necessarily impact individual patients, although that is kind of inherent in the day-to-day work that we're doing here. But I think it impacts an entire community. And I think that this higher level 30,000-foot view of medicine maybe gives this topic a little bit more gravity and hopefully a little bit more relevance to those of us practicing or training in a large metro area like Omaha. And so this is Sacred Heart Hospital. This is shortly after it opened its doors in 1889. Eau Claire did not have a hospital at the time, and it was built in what was then kind of the German immigrant community in Eau Claire, and it was effectively run by a group of Catholic Franciscan nuns pictured here, who had actually fled imperialist Germany due to the persecution of Catholics at the time. And Eau Claire was this quickly growing community in the mid-19th century because of kind of the forestry, logging industry in northern Wisconsin that was booming. And so the hospital was really built with the recognition that the community needed better access to healthcare. And so the hospital that was shown on the last slide was a 17-bed capacity hospital, and it went through multiple expansions through the years. In researching for my grand rounds, I saw some newspaper clippings that in like 1910 it had expanded to a 48-bed hospital with a state-of-the-art horse-drawn ambulance bay that they were all very, very proud of at the time. But in the 60s, this new 9-story hospital was built on the outskirts of town. And it really promised to be a huge asset to the community. It really represented an opportunity for growth and expansion of the city. And I think that the community was really able to grow with increased capacity of the healthcare system to some degree. And so like many community hospitals across the country, Sacred Heart served generations of families, including my own. And so this was actually the bill for the hospital stay when my grandmother was born at this hospital. Of course, the hospital bill back then for a 1-week stay was $35, but because my great-grandfather at the time had 2 sisters that were part of the Franciscan Order of Nuns working at the hospital, they got some big discount. So it was $25 for a week stay in the hospital. And so, you know, both of my parents were born here. My siblings and I were born here. You know, my great-grandfather died in this hospital from complications of prostate cancer. My grandfather died here of a heart attack. One of my uncles was treated here by a surgeon when he had a carotid dissection and was able to prevent any stroke or major deficits. My cousin was treated here by a surgeon when a pitchfork found his popliteal artery. And I think he would like you to believe that this was some kind of a heroic farming accident. It was not. He was just throwing a pitchfork in the air to see how high he could get it. And then it found the back of his leg. But a surgeon was available at Sacred Heart Hospital to clean out the wound and to preserve his leg. But unfortunately, Sacred Heart Hospital closed its doors 2 years ago after about 135 years of serving the community. And they, of course, cited mounting financial pressures. There was regional competition, staffing issues, all of which were exacerbated by the COVID-19 pandemic. But this was one of the oldest businesses in Eau Claire, just behind the paper mill, and I believe one of the churches in town. And with very little warning, the doors were closed. And actually, a second affiliated hospital about 20 miles north closed its doors at the same time after 140 years of serving its community. And similarly, it was amongst the oldest businesses behind the local newspaper and the Leinenkugel's Brewing Company up in Chippewa Falls. And, you know, these 2 hospitals served about 10 counties worth of people, about 250,000 people lived in these areas. And, you know, I don't want to suggest that these 10 counties are now entirely without healthcare, but this was an enormous shock to the communities that had really come to rely upon these hospitals for their care. And so this, of course, was a leading story in the local news, especially because the hospitals just closed so abruptly. Within 2 months of announcing any kind of financial troubles publicly, they emptied the building and it was lights out, doors locked. And this left 1,500 employees and physicians without jobs. And as is often the case in these types of situations, they left the area, they were gone. And the tension went beyond kind of news stories. This became something of a political fight to some degree in the area as well. And as is the case in kind of modern day discourse, people fled to their corners of social media to blame Obamacare or corporate greed and what have you for the reasoning behind the hospital closures. But kind of at the base of all of this was this real outburst of sadness and frustration and fear about what folks are supposed to do and where they're supposed to receive the care they'd really come to rely upon. And so perhaps in this particular instance, it was the result of kind of good old-fashioned American capitalism. There is another hospital in the area, and perhaps that their model of care was more efficient than what these two hospitals could provide in a smaller system. But I would say that my small town hospitals are certainly not the only hospitals that have closed in recent years. Frankly, rural hospitals around the country are in pretty serious jeopardy these days. And so the Shep Center at the University of North Carolina is probably one of the largest organizations that's tracking rural hospital closures in the country. And this is a map that shows that in the last 20 years, there have been just shy of 200 rural hospital closures across the country. And closures obviously is pretty straightforward. It's exactly what happened to Sacred Heart. Doors locked, lights off, no care being delivered here in these hospitals anymore. But conversions are considered hospitals that had obviously previously provided inpatient services that no longer do. They're now a skilled nursing facility or maybe a rehab facility of some kind, maybe a freestanding urgent care center. But at the end of the day, they're no longer providing inpatient hospital services. And this is in addition to another 44 rural hospitals that have become designated as rural emergency hospitals. That was a designation created around 2021. By CMS from the recognition that with the COVID-19 pandemic, there were hospitals that were closing left and right across the country. And so they kind of created this new designation that is unlike a critical access hospital, which can provide some amount of inpatient care for a few days. These rural emergency hospitals are frankly non-inpatient care and are essentially basically subsidized freestanding emergency departments in a rural community. And so there are a lot more hospitals that are facing a similar fate. And you're going to see different numbers published on this particular topic, but this analysis by the Chartis Center suggests that 432 rural hospitals are actively at risk of closing their doors today. And some have suggested that this number is probably closer to 700, which is 1/3 of rural hospitals in the country that are at risk of closing their doors today. And this is a direct result of the fact that in 2025, 46% of rural hospitals are operating on negative margins. And I think in healthcare, we kind of get uncomfortable talking about money to some degree. And I'm not going to delve into the brokenness of the American healthcare system too much here today. But there's a saying that reflects maybe a cold hard truth here, and that is no margin, no mission. And I think this is a stark reminder of how true that unfortunately is in the setting of rural hospitals more generally. And so there's many rural hospitals that have low volumes. They're relatively inefficient in terms of providing care compared to the larger volume, high volume centers. And I think most health economists would concede, and I would as well, that there must be some limit to kind of the degree of inefficiency that we can tolerate as a society beyond which it really doesn't make sense to have a hospital anymore, right? That I don't think we need a freestanding hospital in every small town between here and Denver. That's not a realistic goal. But the hospitals that are closing in rural areas are having detrimental effects on the communities that they had served. And I think this systematic review that I'll be playing through here does a really nice job of kind of showing the gamut of challenges that these communities are facing when these rural hospitals close. And there are some obvious challenges related to things like transportation times, especially for emergency, acute, time-sensitive conditions across important services. And I'll mention here that rural surgeons are generally an important part of obstetric care because they need to be available for C-sections. There's worse mortality for patients, particularly in emergency care like MI, stroke, and trauma, which is obviously a surgical condition. But also there's major employment and economic impacts because people frankly leave communities when there's poor access to healthcare. And so this subsequently leads to workforce depletion, an aging population, declining home values, and so on. And so I think these studies, without delving into each point individually so much, just demonstrates the real snowball effect that the closure of a rural hospital can have on the rural community's health. And so I want to kind of drive home the point here of why this matters and I think why we should care in Omaha. There's a lot of people living in rural America who are just fine living without immediate access to an international airport. They don't have a Michelin star restaurant. They don't have access to go watch a professional sports team just down the road. They don't go to the orchestra, and they're okay with that. And still further, there's a lot of folks who aren't thinking about healthcare every day in the same way that we are. But I think ensuring access to meaningful healthcare services in these communities is more than a convenience to them. I think taking care of patients in rural areas really allows them to continue to thrive and live in an area that we rely on for our nation's food supply, for farmers, our natural resources, our energy system, transportation, tourism, and so on. And so where do surgeons fit into this equation? Well, I think it turns out that surgeons actually play a pretty central role. So this was a paper that was published in Health Affairs a few years back, and it showed that the departure of a general surgeon from a rural hospital, more so than a physician from any other specialty, had the strongest correlation with a hospital closure in that rural area in the ensuing years. And I don't think Dr. Walters is online, so I'll provide my own disclaimer here that this is correlation, not causation. But this is a paper that was not published by surgeons in a surgical journal trying to kind of prove the supreme importance of surgery. I think at the end of the day, the important takeaway is that rural hospitals rely on the revenue of a general surgeon to remain solvent and keep their doors open. There have been some studies that have suggested that in a small rural hospital, upwards of 40% of that hospital's revenue is derived from the work of a rural surgeon. And just as happened in Eau Claire with Sacred Heart, once the rural hospital closed, the remaining physicians across specialties also leave town. So what does the surgical workforce look like in this country? This is a map that was published by the University of Washington, and it shows kind of the number of rural surgeons across the country in rural counties per capita. And a few takeaways here are that there are about 1,200 counties across the United States that do not have access to an active general surgeon. And I think that this impacts probably pretty predictable locations across the country in the Midwest and the Mountain West. Not surprisingly, there's big tracts of land that do not have an active general surgeon. But the United States is a huge place, and there are pockets of rurality across the country, everywhere from upstate New York to California. And I think that each of these areas kind of have their own unique challenges in delivering surgical care in these particular rural areas. And so this was a paper that used workforce data by the National Center for Health Workforce Analysis. This is data that's collected by HRSA and is used to project the American physician workforce throughout the country in the coming decade or so. And when you look at the supply of general surgeons in a metro or an urban part of the country, projected over the next decade, it's actually expected to outpace the demand. You can see light blue is projected supply, dark blue is demand, and this dotted line is the projected adequacy of general surgical coverage in an urban area. And you can see that we're at about 113% of adequacy. But when you compare that to surgeons in rural areas, the projections tell an extremely different story. The supply of surgeons is expected to meet about 40% of demand over the coming decade or so. And so I think when people talk kind of generically about the surgical workforce development across the country, there's a lot of discussion and attention paid to improving the supply of general surgeons across the country. And I think to some degree this is true and important. But I think it's becoming a little bit better recognized that this problem is maybe a little better described as one of surgeon maldistribution rather than supply alone. And so while the distribution of surgeons practicing in rural communities remains pretty starkly lopsided, those surgeons remaining are significantly older than their urban counterparts, with a significantly higher proportion age 55 and older remaining in rural communities. And as this dark box kind of outlines, this older generation of rural surgeons is no longer contemplating retirement. They're rapidly exiting the profession at a higher rate than they would be in an urban setting. And at the same time, young surgeons entering practice are far more likely to work in an urban center than they are to go into a rural community practice. And so I think taken together, all of these data are telling us that we're training close to the right number of general surgeons in the country, but we're not sending them where we need them, which is kind of continuing to contribute to this problem of overall surgeon maldistribution. And so I think I'm mostly done inundating you with the doom and gloom portion of my grand rounds here today. And I want to turn to this question of how do we build up the rural surgical workforce in our country. And this slide, in a lot of ways, preaches to the choir in terms of, I think we're all painfully aware of the many steps that are required to eventually become a general surgeon in this country, with the many steps of education and training along the way. But I put this up here to kind of reflect that I think the answer to building up the surgical training pathways needs to be multifocal, and there needs to be solutions along every step of this pathway to achieve any kind of a sustainable solution to the workforce deficits that I've been discussing so far this morning. And I think it really starts with building interest in the young adults that are graduating high school, frankly, who need to decide if they can see a viable career option and path going into healthcare right out of high school. Because if they're not going into healthcare, they're going to go into engineering or teaching or forestry or what have you, which are all great career paths, but we're losing out on that particular group of young high school students. And from here, I think the point is that there's many off-ramps that are detracting from the end result of getting young students into a career like rural surgery. Certainly more off-ramps than there are on-ramps to get to this final destination. And, from here, I think, becoming a rural general surgeon is not necessarily the finish line, so to speak. There's a lot of challenges to retaining surgeons in a rural community so that they can continue to have a productive 20 to 30-year career in these particular areas. And so I'm not going to go through every step along this pathway to becoming a rural surgeon, but I think this particular paper provides some context and an understanding of what I'm talking about, and some of the ongoing work in the rural workforce development. And so this is work done by Creighton's own Scott Shipman. This was published when he was at the AAMC, and it shows that matriculants into medical schools from rural backgrounds has been downtrending for about 15 in a 15-year span in this paper. And this is problematic in an effort to increase rural physician workforce, because we know that matriculants with rural backgrounds are much more likely to become physicians who return to a rural area and are much more likely to stay there. And so there's dozens of medical schools across the country that are working to improve the development of the rural workforce through training programs that are essentially rural tracks. One of the examples is a medical school where I did my medical school training at the University of Wisconsin. I was part of the Wisconsin Academy for Rural Medicine, or the WARM program. And every program kind of has unique logistical, differences and considerations, but generally speaking, students like myself spend some time at a rural campus for clerkships, and they receive a exposure to these rural experiences that they wouldn't have otherwise been able to receive at the mothership, larger academic center, so to speak. And I think another example of an absolutely well-oiled machine in terms of rural infrastructure is where I'll be heading for fellowship next year at the University of Washington. Their WWAMI program serves Washington, Wyoming, Alaska, Montana, and Idaho. And this is a map that actually just shows the rural sites that they have available for medical students to go to for their training. And it also includes some of the rural residency programs that they have throughout this 5-state, largely very rural part of the country. And I think it's actually worth noting that actually one of our incoming interns next year is a direct product of this WWAMI rural program up at the University of Washington. And so many of these programs are working. They're doing what they're designed to do. The percentage of students who, from these types of programs who are returning to a rural community is approaching upwards of 70%, which is great. But I think another interesting data point of interest is the percentage of students who are entering primary care fields out of medical school. And to some degree, these medical schools may require students to go into a primary care specialty of sorts through various scholarship obligations and things of that nature. But many of these programs are sending well over half of their graduates into a primary care residency out of medical school. And I think taken together, this reflects kind of the importance of recruiting students from a rural background, as well as providing these students exposures to rural experiences during their medical school training. And so I want to pause here and maybe reframe or contextualize the talk a little bit. Why am I spending all this time talking about rural hospital closures? Many of these hospitals are probably not big enough to support a general surgeon anyhow. And now I'm talking about primary care. And so before I dig myself into too much of a hole here, I want to kind of preface by saying I'm not trying to take over the term primary care for general surgeons. My brother is a family med resident, and he can continue prescribing the losartan. I'm totally fine with that. And if he was here, he'd tell me to stay in my lane, that I'm not a primary care doctor, that he is training to do so as a family physician. So I'll kind of offer this olive branch and say that, I think if I was running a rural community hospital and I could only have one physician serving that hospital, I think that would probably be a family med physician, somebody who's literally got training from birth to death and taking care of the gamut of healthcare challenges that the community may be facing. But if I could have two physicians at this hospital, I think that second physician might be a rural surgeon. And so I think for that reason, rural surgery is kind of playing a critical role in primary care, even if it doesn't necessarily fit the colloquial definition of primary care as such. And so I hope I've already made a pretty compelling argument here this morning of the critical role that surgeons play in keeping hospitals open, and that obviously plays a central role in providing access to healthcare services for patients. And I'm going to talk a little bit more in the coming slides about the broad scope of practice that rural surgeons take on. But rural surgeons are accountable for a huge proportion of procedure-based care happening in a rural hospital that medical providers just simply don't provide. And I'll pause here and state that APPs are absolutely invaluable in a rural community. They make up a huge proportion of the health care workforce, particularly for primary care. But they don't really offer the procedure-based care that a surgeon can. Everything from basic health maintenance like a screening colonoscopy, elective operations like hernia repairs and cholecystectomies, acute care like appendectomies that keeps patients in the community where they want to be taken care of, rather than having to drive several hours away to receive their care, or taking care of emergency situations like temporizing a sick trauma before transferring them to a larger level 1 center where they need that higher level of care. These are all the responsibilities of rural surgeons. And so I think in talking with many of the rural surgeons through the work that I've been doing and rotating in these types of areas through medical school, there's no question that these rural surgeons become an integral part of the community that they're caring for, and they develop these longitudinal relationships with patients and families in the same way that a primary care PCP physician might do. And so I assure you that this is more than semantics, and I'll kind of get to the point here as to why I think this is so critical in the coming slides. So the subtitle of my talk this morning is Advocacy in Rural Surgery. And just like I'm not an expert in rural surgery, I am certainly not an expert in advocacy. But I wanted to talk a little bit about how advocacy can really represent the many different interests that we may have as surgeons, including how critically important rural surgery is to their community in my case. And I think using myself as a little bit of an example, I think physicians can be a little bit intimidated by the idea of advocacy, but are probably better at it than they realize when they're engaged in something that they're actually pretty passionate about. And so advocacy can take on many different forms. I think, honestly, advocacy can be as simple as taking time to just read about and understand current issues because, as surgeons and trainees, we interact with a lot of different people in our day-to-day lives, and we understand the issues better. We're able to convey them to people who look to us as leaders in this field. And so beyond that, advocacy can obviously take on forms like talking in a forum like this, writing a letter to your representative if you're feeling so moved, writing an op-ed. If you want to join various committees in the surgical societies that represent many of our issues, these are all great ways that you can participate in advocacy. Or advocacy can be as extensive as flying to DC for a few days and spending time talking with your senators. And I wanted to share this as just one of the great examples of how I feel that I've been able to advocate for improved care for rural populations throughout the last 5 years here in my training. And so at this year's Leadership and Advocacy Summit in DC, we were able to talk to Senators Fisher and Ricketts, staffers, about a handful of bills that are impacting rural, not even necessarily rural, various bills that are affecting surgical care in our nation. And similarly, at last year's Rural Surgery Symposium, I was able to moderate a discussion with Representative Don Bacon, who is actually one of the co-sponsors on one of the bills that we talked to our representatives about last month. And that is a bill going through Congress called the Ensuring Access to General Surgery Act. And so I doubt that the president is going to be calling a press conference to address the nation when this gets signed into law, and that's okay. But I think it directly impacts everything that I've been talking about here so far this morning. And effectively what this bill does is give the problem that I've been talking about a name. The federal government already designates what we call health professional shortage areas for primary care, mental health, maternity care, and even dental care in the country. And this bill would essentially compel HRSA, who designates these areas, to do the same thing for general surgery. And I think that this matters because once a health professional shortage area has been designated for general surgeons, we can then take the opportunity to open up funding lines that would support surgeons who are going to these particular areas to practice through established programs like the National Health Services Corps that helps to pay off student loans and support physicians and are really designed to bring physicians into the rural workforce. And so this is just one example of where the rubber meets the road, so to speak, in advocacy work. And if this is something that you might find of interest, that's great. We can talk after grand rounds. The American College of Surgeons has many great opportunities and resources to get involved with advocacy. And conversely, if talking about bills going through Congress put some of you to sleep, that's fine. My hope is that just talking about this particular issue is a great start in kind of addressing some of these particular challenges. And so I want to move on to one more topic here that's garnered a lot of discussion in the world of rural surgery, and that is rural surgical training paradigms that are evolving to prepare surgeons for entering practice in a rural community. And in my opinion, I think we're really going to struggle to overcome this rural surgical workforce challenge that I've been talking about this morning until we figure out how to do this better. And so I think to understand how surgical training needs to evolve, we need to understand what it is that is expected of a rural surgeon. And so this was a paper that was put together by the folks up in North Dakota. And it basically is just enumerating the case makeup of a rural surgeon. And most of this probably comes as a little surprise. The API, the chole, the hernia, the skin soft tissue, breasts, SBOs, these are all the purview of a general surgeon. But I think two noteworthy features unique to rural surgical practice are a heavy emphasis on endoscopy and some subspecialty procedures that would generally be covered by a different surgeon in an urban center like OB-GYN care, to some degree vascular, thoracic, ortho, ENT, things of that nature. And so some of these specialty procedures, as I've said, are certainly still within the purview of a modern general surgeon. Basic vascular procedures like putting in a port is well within our wheelhouse. A thoracic operation or two is within our wheelhouse, and even some plastic surgical cases and so on. But there are several that are not a standard part of a general surgeon's training nowadays, as is required by the ACGME and the American Board of Surgery. And this is especially true in areas like OB-GYN, as well as urology, ortho, ENT, and some others as well. And so while indeed a big proportion of what rural surgeons do kind of fits the definition of bread and butter general surgery, these two areas should not be conflated. And so I think preparing new surgeons to take on this unique practice makeup has led some to embark on kind of the development of a rural surgical training curriculum of sorts. And there's a few different versions of this published in the country that essentially incorporate these various specialty areas of interest into a training model with dedicated rotations for OB-GYN as an example. But the Advisory Council on Rural Surgery at the American College of Surgeons has suggested these 4 core components to a rural training arrangement. And I think these 4 are really pretty critical, in that the clinical experience in a rural setting is central to becoming prepared to work in these types of settings. This type of an experience basically tells residents maybe not what they can and cannot do, but what they should and should not do, given the resource constraints that they're going to be experiencing in some of these rural, less resourced settings. The second being a robust endoscopy experience. And I think that this needs to go beyond just being good at a screening colonoscopy, for example, but really develop some skills in more therapeutic procedures like treating bleeding, and potentially even taking on procedures like ERCP to treat some emergency situations like cholangitis, as an example. This third point we've already talked about in many of the subspecialty areas of exposure, but this fourth point is that to get an adequate training in these areas, there really needs to be few, if any, competing residents or fellows who are also trying to achieve their numbers in these various cases. Right? If you want to get good at C-sections, you need to be in a place where you can be doing a lot of them without OB-GYNs also trying to get, duly the numbers that they need to get good at this particular procedure. And so over the last 20 years or so, there's been various training arrangements developed that help to facilitate these types of exposures for residents in rural areas. This can be as intense, if you will, as a program located in a rural setting where essentially 100% of their training is intrinsically rural. There's other programs that have created these separate rural tracks with dedicated time spent at a rural site. And these are usually separate positions within a larger residency group with kind of a unique NRMP designation that you're specifically interviewing for in these programs, such that maybe 1 out of 7 residents in a class might be considered the rural resident. And usually these residents would go to a rural site somewhere between their 2nd and 4th years and spend anywhere from 1 to maybe upwards of 3 years in these rural sites to gain these experiences. And then from there, there's many programs across the country with varying degrees of elective experiences for anywhere from 1 to 3, maybe even upwards of 6 months of rural rotations that would be kind of an elective option for some of these residents. And of course, nothing says that you need to be trained in a rural setting to practice there. And so there's many residents that go into a rural practice without any exposure to a rural setting during their training whatsoever. And so because of this really significant diversity of training experiences across the country, there's kind of this ongoing debate about what is considered to be adequate training, especially because about 80% of residents nowadays go on to complete secondary surgical training in some kind of a fellowship. And so as it stands, some might argue that with appropriate focus on this broad surgical practice, that 5 years can be adequate to prepare rural surgeons for practice. While residency maybe doesn't necessarily prepare you for 100% of what you're going to need to do, an appropriate broad-based surgical training can prepare surgeons to take on this broader scope of practice, and perhaps with an appropriate level of senior partnership mentorship when you get to this particular rural location. On the other hand, others have argued that rural surgery is such a unique specialty that it really would require an additional year of fellowship training that prepares these surgeons to take on this additional exposure to things like OB-GYN, ortho-urology, and others that are not kind of part of the typical surgical training paradigm here in the country. And you can imagine there's fairly strong opinions on both sides of this argument. And I am not going to render an opinion and frankly, I don't know that I have a good answer here myself. But I think a potential middle ground that has been suggested is that of a focused practice designation specifically for rural surgery. And so, as we all know, general surgeons complete their ACGME accredited residency. They take some exams. They become board certified in general surgery. And following the completion of residency training, surgeons can then take on the option of completing a fellowship where they become board certified in a surgical subspecialty like pediatric surgery, vascular surgery, colon and rectal surgery, surg-onc, surgical critical care, you name it. But a focused practice designation kind of falls somewhere between these in that people can gain certification in an area of expertise after completing a fellowship, or they can demonstrate kind of an expertise in this area through their career focus. And I think the best way to describe these FPDs is to use metabolic and bariatric surgery as kind of a familiar example that uses the FPD model. And so there are, of course, fellowships available for bariatric surgery nowadays. You can go on and gain that experience through a one-year fellowship. But completing a fellowship is not entirely necessary if a surgeon like Dr. Javi, who's here today, is able to demonstrate a particular expertise in this area through their career accomplishments. They don't need to go on and do a fellowship to be, a bariatric surgeon. And so I think this kind of example shows some parallels to rural surgery. A RU and Y is certainly within the purview of a general surgeon, but there's kind of this recognition that there is added value to have a higher volume of this type of practice to be performing these types of procedures. And as I said, you can maybe see some of the parallels to rural surgery that might be taking on a broader case mix, like the OB-GYN related procedures and the rest. And so I want to close here with just a few more slides that are kind of discussing just a few more of the challenges rural surgeons are facing in taking care of patients out in the community. The problem with that is that I could probably spend another 5 or so hours talking about any one of these problems, and there are still more challenges that didn't even make this honorable mentions slide, so to speak. And so I want to reiterate here that this is not the experience of myself. Rather, these are just the challenges that we're hearing rural surgeons discussing repeatedly through various forums. And I think it kind of leaves us maybe with a pretty daunting outlook on how to improve rural surgical care and access. And so the question becomes, where do we go from here? And I think it starts by taking advantage of a crisis. This is not at all intended to be a political statement. It's just a statement of fact that healthcare spending, including insurance coverage in rural America, took a pretty serious hit. With the most recent budget reconciliation bill that went through Congress this year, untold hundreds of billions of healthcare dollars were cut from the federal budget over the next decade. And that may be good, that may be bad, that may be overdue. I'm not going to provide an opinion on that matter, but it's just the fact. And these cuts were attempted to be offset by the Rural Health Transformation Program administered by CMS that introduced $50 billion in investments in rural healthcare infrastructure. And I'll just say here that, by itself, this $50 billion isn't going to come close to fixing rural healthcare. But what I do think is that it represents maybe a recognition that there is a crisis in this particular area and maybe an opportunity to provide some improvement. So in closing here, I hope that I haven't entirely discouraged everyone from the prospects of rural healthcare. I suppose the goal of my talk here today was really to present some of the challenges facing rural surgeons and the rural surgical workforce, and there's no doubt that they are immense. And so hopefully you found something of a silver lining in that rural surgeons are an invaluable part of the functioning healthcare system in this country, and a career in rural surgery can have a huge impact on the community that you would potentially be serving. And so these are my references. Thank you all for your attention this morning. It's a real pleasure to talk about something that is near and dear to my heart, and I'd love to hear any additional perspectives from the audience and obviously take any questions.
I guess I have a question. Thank you for the presentation. So my question's a little bit practical. I feel like I work not in a rural hospital, but a small community hospital with limited resources.
Sure.
Right? We don't do trauma at the VA. We don't really have a blood bank. We don't have a ICU. All these things that we take advantage of. And from a personal perspective, when I first started at the VA, fresh out of fellowship, my chops were very good. I could do anything, right? I did Whipples. But then once you hit year 5 and you've done one Whipple a year, the question is like, why am I still doing this operation when there's a hospital that does a lot more of these every year? So my question is pretty practical. I think it is sort of unreasonable to take one surgeon and plant them in a rural place and say, we expect you to do like 200 different surgeries, and you're only going to do like 5 of those a year. And we expect that to be a viable model. I don't think that's a viable model, and I don't think that's a good one for the community or the surgeon. Has anyone talked about a different model where instead of just sticking this one person in this hospital full time, that there is maybe some sort of rotation or residency that people do for a couple months of the year? I understand that's like a huge lifestyle issue for people with families to be away, but I just don't think it's like an actual viable process to be an expert in all of these things, like for any given amount of time.
Yeah, I couldn't agree more. I think that some of the challenges that we're facing is that, this isn't the good old days of surgery where, surgeons would train to be doing everything. They would do a Whipple on Monday, they'd do an endarterectomy on Tuesday, deliver a baby on Wednesday, and they were just kind of the everything surgeon. And I think we've really found in the last several decades that, there's a reason that we have centers of excellence and level 1 centers and all the rest for high volume care for complex surgical procedures. And so you're absolutely right that there is a challenge in training a rural surgeon to be able to take on this really broad depth of procedures. And so I think that there needs to be some more work. I mean, I think that this is kind of a new phenomenon in the last couple of decades here, where we're trying to decide, what is an appropriate breadth of cases as there's more advances in the surgical field. And I don't have an answer as to like which procedures should and should not be performed in a rural area. I think a Whipple would be crazy to be trying to do in a low resource type of a hospital. But at the same time, these patients in this area rely on, receiving emergency care. And so is something like an ERCP totally out of bounds as a consideration for treating somebody with cholangitis 4 hours away? I don't know.
My question is, if you do one of those a year, by year 5, you've done 5.
Yes.
Are you still the person who should be doing that procedure? That's to me is the question.
Yeah, and I think that's still an open question. And I think, a Whipple and esophagectomy, I think the answer is no.
Obviously, I just put that out because that's me. But it's like, how many do you need to do?
Yeah. As you become progressively more complex in that, how many colectomies should you be doing? All right. So if you do, 15, 20 colectomies a year, is that enough? I don't know. I think that's still an open question and something that we need to grapple with. Because I think patients still want to receive care in these rural communities. And there are surgeons that are certainly willing to take on these types of procedures. But I don't know what the answer is for those numbers.
Yeah, I just think outside the box. Yeah. Like that surgeon, you just need to get them more cases.
Yeah.
So is there a way to do that in a model? Is anyone talking about any different models?
So there are various models that have been underway. I think a lot of it really comes down to kind of connecting them in with a larger academic center like this one. One that comes to mind is University of Alabama. When I was interviewing for fellowship, they kind of talked about how the University of Alabama in Birmingham actually employs rural surgeons across the state. And so they are actually literally part of the faculty at UAB. And so while they're out in the community 3, 4, 5 hours away, away. They're still connected with UAB. If they want to come do cases, I think that's still an option for them. They still have rotational support to help them through these types of, limited call coverage and all the rest. And so I think that's just one example of a model that's been developed. Yeah. I think Dr. McCall had her hand up.
Medical school also where we had a rural experience. And so I went to Plainville, Kansas, which has less than 1,000, people who live there. And the big city is a few hours away, and is Hays, Kansas, where it's the big city because it has a Walmart. But I think it gave me a different perspective on what people are able to do in rural communities. And also I think, some of your figures about the hospitals that are staffed by surgeons are probably underrepresenting, because it's probably being double counted. So
Yeah.
like the hospital that I was at was staffed by a surgeon the third Thursday of every month. And
Yeah.
so they operated in the morning and they had clinic in the afternoon. And then every other day of the week, they were going to the various, other hospitals within a 4-hour radius, of the town that we were in. And so I think it's really important, one, to understand that when you're accepting transfers at a big academic center, what they're actually capable of, and then giving them some grace, I think sometimes is really important. And then just kind of understanding that it's a big problem that we need to find some sort of solution to.
Yeah. Yeah, I think you just hit on one of the biggest challenges of really studying this problem is, how do you amass this data to really understand what surgeons are doing in the community and what hospitals are they actually even serving. I mean, it showed, in the state of Montana, for example, it showed that there's no active general surgeons in this area. That may or may not be true. I mean, there's some surgeons that own their own helicopter, for crying out loud, and they'll fly around the state or the region to provide care to these hospitals. And so, yeah, it's just so hard to really enumerate these types of challenges.
Dr. Reetz?
Yes.
This is Al Rafai. Congratulations on a wonderful grand round. Learned a lot from it. And congratulations on a wonderful career trajectory on how to take an important cause and run with it. Today is another proud day for the department. I still remember the first few weeks when we had our listening tours, and you and other residents told me, what will a surgeon from Washington, D.C. do to rural America? And it was very transformational for me and inspiring. And look where we are now with all the work. And it's emblematic how residents in any program, especially our program, have the potential to take an important area and develop leadership and agenda around it. And I'm also thankful for Dr. Nathan, who's with us on Zoom, who participated and has been a strong collaborator and a proponent of this agenda as well. So well done. Proud of you.
Thank you.
I agree. Great talk. Really, really impressive. How do you think the robot's going to transition, help with this, rural surgery? Especially I went to a dinner last night on the DV5, and there are a lot of new little and fancy tools you can use to kind of help, surgeons in a rural community with it. So do you think there are going to be more robotic procedures in the rural area or less?
I think if you asked the intuitive rep, they would tell you that we should have a robot in every hospital in the country so that rural surgeons can take on these procedures. And the robot is a great tool. There's absolutely no doubt about it. As a surgeon, I can take care of a patient by myself on the robot because, especially with the DV5, I can adjust my own insufflation pressures and all the rest, right? I mean, I don't rely on as many assistants to be available because I'm driving my own camera and all the rest. I don't know. I mean, I think that's there needs to be a cost-benefit analysis to be done, and we're not good at that in American healthcare. And so I think that there's just going to be continued emphasis and integration of the robot into rural areas. And I don't know that I've got a good answer as to whether or not that's appropriate.
So I was going to ask from maybe a little bit different perspective for those of us who don't anticipate working in rural communities, but do anticipate taking care of patients from rural communities, how you think we can strengthen those relationships. Something I noticed on head and neck in particular, you'd have patients with really complex surgical procedures that aren't well understood by the general, population, by the emergency physician population who lived 6 hours away from Omaha, right? transplant is very, very similar.
Yeah.
What can we do to strengthen those relationships with rural communities to make sure those patients can get the care they need in their community or get referred in a timely manner to places, that provide things that they maybe can't get at home?
Yeah. So I think at a simple level, kind of what Dr. McCall said is to give a little bit of grace and open the doors and, to avail yourself to rural surgeons in a way that, gives them something of a lifeline when they've got a complex issue out in Scotts Bluff, hours away from anything, a high level of care, to just, give some grace and be available for these types of surgeons. But generally speaking, I mean, I think this represents a more challenging healthcare system type of a challenge. I mean, when we talk to rural surgeons in these areas, there's a lot of them saying like, who do I even contact, right? Like what phone number do I call when I've got somebody with, a large gastric cancer? I call, general surgery at Bergen Mercy, and I maybe get, transferred to a surgeon that does not operate on the stomach. And so I think that there's an opportunity here for a systems level improvement that maybe kind of like I talked about with UAB, right? Kind of integrates rural surgeons into an academic center at a little higher level so that they know who to call when they have a complex problem.
All right. Well, thank you, Dr. Reetz, for a really great talk. Just my last question is, any advice for the attending residents, medical students, as you contemplate graduation?
Oh man, that's usually reserved for visiting professors. I don't know that I have any great advice. I think if anything, as I talked about, advocacy is something that maybe we're a little intimidated by. It's totally outside of our wheelhouse in a lot of ways. We spend all this time learning the nuances of medicine and how to take care of patients, but it's a critical part of what we do. And kind of what I described is, as I said, something of an example of where the rubber meets the road. And if you have a real passion for any particular issue, this is how it gets done. It doesn't get done by talking about it in the doctor's lounge. And so, I think you need to find an area of passion, and I think there's something to be said about digging into that problem. All right, thank you.